I do not know how to improve.
Also, your voice is echoing.
Voice is echoing.
Some-
It is a small room. Not a small room, but
And as if it is coming from a very far distance. It is like that.
Sir, I think mic is far away.
Check your internet connectivity, Devjyoti.
internet is different one. We are doing fiber. Yes, there is 5 bar, all is correct. Okay. So do you have your mic? Because today we are using another mic. Mic is today I am using the corporate microphone actually. That might be the problem. Or I need to put the computer slightly up. Now is it better? Or still the same?
It is still the same.
Sir,
your
your
voice
voice is still not clear.
Devjyoti, what can be done? You can, take the lapel like other days, and meanwhile, Kanchan can start one count, or I can start my lecture also.
No. I think I got the problem.
But your voice is really not good.
Now how it is?
Now it's fine. Now it's
Now
fine.
it's improved. I told you I got the problem. Okay. So let's start with the today's topic, that is the fibromyalgia. So fibromyalgia is one of the very common diseases that you need to encounter in your daily practice. So what fibromyalgia is? Let's start with a case. Shadhana, a 40 years female attending pain clinic with history of pain from scalp to toe for last 4 years. Sometimes pain is burning and cramping in nature. She gets tired easily and aches with any activity. Her sleeping is restless. She awakes tired and complains of recent loss of memory. All her investigation reports are within normal limits. So this is the typical history of the patient. And what happens? Commonly, these patients come with a multiple reports in hand. Okay, when we see the patient is actually visited many doctors, and when they come, they are doctor. I do not find any report. All reports are normal. Someone suggested me to go to the psychiatrist. Am I mad? So this type of questions, patient comes, and patient is really very anxious. Now, let's see what fibromyalgia is. It's a complex chronic pain syndrome which is affecting 2 to 4% of the population, more common in females, and this is very difficult to cure, seldom curable. Widespread muscle pain, presence of trigger tender points, okay, and other symptoms exist like fatigue. Okay, 3-4 symptoms are very important for fibromyalgia. Number 1, easy fatigability. The patient will say that I am getting tired in all the activities. The whole day I am tired. Number 2, patient is having another very big problem is that unrefreshed awakening. And this is a very common symptom that patient tells. The whole day I feel sleepy. In morning when I get up from bed, I still feel I need some more sleep. So that is known as the unrefreshed sleep. Because if your non-REM sleep is more, you will definitely get refreshed. But these patients never get refreshed on sleeping. And third, most important criteria, what happens? The recent memory is reduced. It is not gone completely. What happens commonly? The patient has put, for the female patients, put something on for cooking and then she forgets. And ultimately it's burned. So this is encountered by the patient very commonly. Usually 20% to 50% patients may suffer from depression along with it. Definitely anxiety is there. And one of the important criteria is the sleep disturbance. Insomnia is a very common association, common problem with the fibromyalgia. And some studies say it is the cause, some studies say it is the effect, but sleep disturbance is associated with it. Okay, morning stiffness, paresthesia, headache, that might be there, and there may be an array of symptoms, not only limited to this, like heartburn, this falling hair, lot of symptoms are usually associated with it. And fibromyalgia may be associated with the rheumatoid arthritis or sometimes the systemic lupus. This is a quite common association for the fibromyalgia. Now coming to the diagnosis. So how you can suspect it's a patient of fibromyalgia? First of all, it's a chronic pain. It's a widespread musculoskeletal pain and lasting longer than 3 months. That means it's a generalized all 4-quadrant pain and which lasts for more than 3 months for the patient. So it's chronic. In addition, axial skeleton must be involved, and this is the older criteria of 1990 criteria. Today, we do not follow this criteria because there are certain limitations associated with the criteria. So what that criteria in past was there, the patient, it is used to say that there are fixed 18 trigger points. These are those trigger points. I'm not going into the detail of this because this is already obsolete. So if the patient is having pain on pressing these areas with more than 4 kilogram of pressure, then the patient is said to have positive for fibromyalgia. But what was the limitations for that definition? First of all, variations. Some patients do feel pain. In some days the pain is more, in some days the pain is less. So what happens with that criteria? A patient during his course of the disease, during some days may have fibromyalgia, in other days the patient is not suffering from fibromyalgia, but that is not possible. So variations are there, but this diagnosis doesn't takes care of those variations. Next, symptoms other than pain. I have already told that fibromyalgia is having a wide array of symptoms. So they have not considered those important symptoms other than pain, like unrefreshed awakening, like easy fatigability, like cognitive impairment. So these are very important criteria for fibromyalgia. But with this definition, all those important criteria are put out of the definition or criteria. So this again corrected by ACR, that was proposed in 90 by ACR. In 2010, there is a revision of that criteria as well. Now, these are the frequency of symptoms. So what are those wide array of symptoms? Muscle pain, definitely it's in the definition, so it's in 100% patients. Fatigue, almost 96% patient. Insomnia, 86% of the patients. Joint pain in 72% of the patient. Headache in 60% of the patient. Restless leg, 56% of the patients. Paresthesia, memory impairment, leg cramps, poor coordination, anxiety, major depression. So patient suffers from these all conditions. Now, what we need to know today is the today's criteria, but you can say it's the ACR 2010 criteria, and that is still we are having this criteria, and this is a screening combined tool. Okay, so they have in the criteria they have stated why they have to change to the new criteria, because they have written that limited requirement to perform the tender point examination. So you have to perform the tender point examination if you follow the older criteria. Then ultimately it is not reliable and difficult in clinical practice, delays in diagnosis and management, because the patient is having other symptoms but the pain is less. Then in those cases you might miss this diagnosis even late. So ultimately when you will be diagnosed, it is already late. Newer criteria, ACR 2010 provides the more practical screening tool to use for the primary and specialist cares. No longer requirement of this tender point examination. Correctly classified 88.1% of the cases defined using ACR 1990 criteria. Uses widespread pain index and symptom severity index. I am coming to next. What are those things? So depending on these two criteria, we can diagnose a patient of fibromyalgia. So there are some minor updates in 2015-16, but they are really minor. We are not going to discuss those important things. Okay. So this is the criteria part. So what is WPI or widespread pain index? This is actually the whole thing is a form or chart like of thing. If you search in the internet, you will get it, or I can share it in the group as well. Okay, so you can take a printout of it while seeing the patient and you ask the patient to fill up this form. It's so simple. So what is widespread pain index? This actually indicates in how many areas the pain is. Okay, body is divided into 19 parts, 0 to 19. And the patient has to write in which areas or might tick in those areas where the pain is. Okay, so jaw right, jaw left, left, abdomen. So like that. It's very simple. So the patient writes, then it's your job to count and you have to put the WPI index. Okay. Next, we need to count the symptom severity index. Here it is placed like Likert scale. So what are those? They have considered 3 among those symptoms are very important symptoms. What are those? Fatigue, waking unrefreshed, memory and attention impairment. Okay, or you can say it's a cognitive impairment. And the somatic symptoms. All other somatic symptoms they have grouped into a single category. So if there is no somatic symptoms, these somatic symptoms are written, okay, in very small word below. So when you will be seeing the recording, you can see it, and I will share it also, the somatic symptoms. And the refreshed newer criteria that is written much better way. So the thing is, but things are the same, it's not different. So fatigue, next, waking unrefreshed, and third is the memory impairment. And it is divided into no problem, slight or minor problem, moderate and severe problems. The patient has to assess and they need to write the score. And among those symptoms, if there is no symptom, it will come under 0. If it 1 to 3 symptoms, it will come under 1. 2 symptoms, 4 to 6 symptoms come under 2. Like that, you need to write the score and you have to put the total symptom severity score. Now, before putting this patient to criteria, there are some important things, investigations. That is the screening investigations. That is very much important because, see, it is a diagnosis when you are, these things are normal. That means CBC, ESR, CRP, LFT, CPK, TFT, thyroid function test. So if these cases are normal, then you put the patient to this test and you need to record these findings as well. Now, you put your duration of symptoms, underlying diseases if any, and medication receipt in past 1 month. Now coming to the criteria part. If widespread pain index is more than 7 and symptom severity score is more than 5, or widespread pain index is more than 3 to 6, within 3 to 6, and symptom severity score is more than 9, the patient is classified as having fibromyalgia. Number 2, symptoms have been present at a similar level for at least 3 months. So that is the duration criteria that was in the old criteria as well. The patient does not have any disorder that would otherwise explain this pain. So it is, you can say, it's a diagnosis by exclusion as well. If other diseases can explain these causes, then you should not diagnose the patient as the fibromyalgia. Now, meet the patient, meet the criteria, do not meet the criteria. Okay, so that you need to do to diagnose fibromyalgia. Now coming to the a little more difficult part. But before going to that part, pathophysiology. So if you have any question in understanding these charts, hello, am I audible?
Yes, sir.
Okay. No problem in understanding because they are very simple and most of the chart is self-explanatory. So you might not need any problem, might not have any problem in understanding. So let's start with the pathophysiology of fibromyalgia. Remember, when we have a lot theories, hypotheses, that means we are not very sure which one is actually the perfect. This is true for this fibromyalgia as well. Okay, so first line is the pathogenesis of the fibromyalgia is still not clear. Uncertain clinical and biological. Why it is not clear? Because of the uncertain clinical and biomechanical findings are well documented. There are several hypotheses based on these findings, some of which are well accepted, some of which are questioned. So let's discuss in a very short what are those findings. So one of the findings is that the patient is having minor older CNS or spinal cord trauma, they're having more chance of development of fibromyalgia. So one hypothesis too that it may develop after a major trauma. Next, it is found that the substance P level in the cerebrospinal fluid is higher in fibromyalgia. So it may be caused by the increased substance P in the CNS. Low serotonin level in the platelets and CNS. So that might be another finding that might be associated with the fibromyalgia. Low levels of the ATP in RBCs and trigger points, that might be a cause of fibromyalgia. Dysfunction of the hypothalamo-pituitary adrenal axis might cause fibromyalgia. Low growth hormone level, which is actually in adult doesn't cause growth, but it helps in maintenance and repair. So if the growth hormone level is low, it might cause fibromyalgia, and this hormone is usually secreted during the non-REM sleep. So here the relation between the insomnia and fibromyalgia pain is also somehow comes out, but again the things are not clear which is the primary event, whether the fibromyalgia is causing insomnia or insomnia is causing the fibromyalgia. Next, it has been found that nerve growth factor is the 4 times higher in CSF in fibromyalgia. Strong familial pattern in females are often affected. That also explains that there might be some genetic variation or genetic linkage. And definitely one of the causes is the non-restorative deep sleep. That is non-REM sleep is absent, delta sleep is absent. So as I have told that head injury and the cervical spine injury that might cause fibromyalgia. So it is one of the hypotheses for the fibromyalgia. Next is that the DNIC system, though it is a hypothetical system practically. So it is, the experiment is also there that one hand is immersed in the uncomfortable hot water. So one small part is you put for the first time, then what happens? It causes more pain. And then as you are immersing more, the pain reduces. That is because the DNIC system, basically the gates in our different levels that inhibits the pain signal, and that is usually absent in fibromyalgia. So it sometimes, in my understanding, I do not know whether it is written anywhere or not, but what I feel is fibromyalgia is basically a widespread chronic sensitization without the pathology, where we are not getting the pathology, but rest all other features are like a generalized chronic sensitization. But anyway, it is not written anywhere. So this is my understanding with the cases and everything. So next is the substance P in the CSF. It's 3 times higher. So actually this causes exaggerated nociception. Next is the association with the serotonin. So serotonin is an important mediator for the inhibitory pathway. Now, if the concentration of the serotonin is reduced, then there is chances of fibromyalgia also. So disorder of the sleep, pain perception, headache, and mood disorder. That is why it is said that fibromyalgia and depression is usually associated, and 20% of the fibromyalgia patients is having the major depression. But remember, these are all hypotheses. No one knows which one is the best suited explanation for fibromyalgia. Similarly, as I have told, low ATP levels in the RBCs and trigger points that might cause fibromyalgia. Low ATP, increased calcium level, sustained muscle construction, muscle fatigue, and other CNS changes. Hypothalamo-pituitary adrenal axis, stress causes corticotrophin release. Then it ultimately glucocorticoid. So low free cortisol level is found in the fibromyalgia patient. So that might be another cause that might go for the fibromyalgia. Nerve growth factor is found increased in case of fibromyalgia patient. So what they can do, they can alter the nerve connection. So again, it's going in favor of the same thing what I am telling. It's a part of chronic sensitization also, but there are these crosstalks and communication and exaggeration as well. Okay, so interconnection with other segment increases the area of pain. Interconnection between the A delta and C fibers with the habitat fibers called allodynia, where one modality actually of sense is transmitting into pain or changed into pain. That is why pain patients, fibromyalgia patient, what happens when the patient states that when I am lying down in bed, the portion which is in touch with the bed, that is also painful because of pressure. So there the pressure sense is converted to the sense of pain. So threshold of pain is actually reduced. So everything the patient gets pain. Even you put the cuff and when you are inflating the cuff, patient says, ooh, patient feels pain. So this is what we commonly get in fibromyalgia. Growth hormone, I have already told that during the delta sleep or the deepest part of the non-REM sleep, there is release of growth hormones. Growth hormone works as a repair hormone. Okay, insulin growth factor 1 in the liver. So low levels of the IGF-1 is a specific and sensitive for fibromyalgia. Though these tests are experimental and it is not possible to do it clinically and it is not available at market. Okay, sleep, it is closely related with fibromyalgia. It may be related through the growth hormone, it may not be related to the growth hormone, but the thing is, the patient suffers from insomnia and non-restorative deep sleep is a cause of fibromyalgia. And there is more alpha activity in the EEG of the patient. So these are the findings for the patients. Now coming to the microglia and astrocyte. So we all know these are the matrix cells of the CNS. We do not know what their function is, but it has been found they have some excitatory cytokines and that might increase the pain sensitivity as well. Okay, and there is a link between the lazy COMT gene or catechol O-methyl transferase gene is found, and that might have a link in the fibromyalgia. So autonomic nervous system may cause some factors of fibromyalgia, but these things are mainly theoretical. This is just for you to think, you to read more, but really in practically what we need, I have already stated the first part. So what is the no single explanation? So what does it mean? That none of these mechanisms are really true. Still, we do not know which is the exact thing is fibromyalgia. But what we know, how to diagnose and how to treat. But sometimes what happens, these patients are very difficult to treat. Okay, so central sensitization, widespread central sensitization is the key of the fibromyalgia. Now coming to the treatment part. This is very, very important. The diagnosis management, this you should know. First of all, test you should be doing, you should be excluding any other disease. Patient should not have those diseases. Now, what are the drugs you can give for the fibromyalgia? For the pain, you can give tramadol, paracetamol. Even in some books I have seen, even the short course steroid, they have also tried. Okay, but if you go for the evidence, the most evident medicines are actually 3. Among those, one of the important medication is the antidepressant, and the most important antidepressant here are 2. One is the duloxetine, and the other is the milnacipran. If you see the FDA recommendations, these 2 antidepressants are more prominent in action. Okay, though the other older agents like the nortriptyline, like the amitriptyline, they work in the fibromyalgia as well. Next is the selective serotonin reuptake inhibitor. When the depressive component is more, you can add this SSRI. But remember, usually we do not prefer SSRI with the antidepressants. Why? Or with the tramadol. Okay, we do not prefer this combination. Though it is rare, but it has a devastating complication, that is the serotonin syndrome. That is why we usually prefer only one drug at a time. Okay, or we can give one antidepressant and along with one anticonvulsant. Usually we do not mix 2 drugs. Okay, including tramadol, because tramadol is having also activity on the sympathetic system. Okay, so SNRI, serotonin norepinephrine reuptake inhibitor. That is the duloxetine. Okay, that is the milnacipran. No, okay, that is duloxetine. And noradrenergic enhancing serotonin reuptake inhibitor, that is the milnacipran. So These drugs are prescribed for those patients. Now coming to the anticonvulsant, the most evidence-based is the pregabalin, the Lyrica. So Lyrica reduces pain and improves daily function for some patients with fibromyalgia. So this is the first drug which is approved for the fibromyalgia. Next is duloxetine. Third is milnacipran. And the first armamentum in our hand is Lyrica or fibromyalgia. This is the fiber product. We are not Lyrica but pregabalin. Okay. So what are the how to start the pregabalin? Usually pregabalin is started at 75 milligram at bedtime. Some patients may complain the dizziness, sleepiness in initial few days. So in those cases, we can reduce the dose to 50 milligram as initial dose also. After the patient is settled, we can gradually increase the dose to 75 milligram. And the maximum dose is 300 milligram, but rarely it is required. Most patients respond at around 150 milligram dose. Okay. Now, the problem is sleepiness, blood vision, weight gain, dry mouth, swelling of the hands and feet are well reported in my patient. Definitely, I have found the increased sleepiness and definitely the swelling of hands and foot. These two complications are quite common. So you have to be ready to manage those complications. So one of the thing important is the reducing the dose. Now coming to the SNRIs, so duloxetine, which is 5 times more potent on the 5-hydroxytryptamine, that is serotonin, than norepinephrine, and milnacipran, which is the twice more potent and norepinephrine than the 5-hydroxytryptamine or serotonin reuptake. So there is actually, when we say the selective serotonin reuptake inhibitor, the ratio at which it inhibits the reuptake of serotonin and the norepinephrine that actually changes. So duloxetine causes more depression, the reuptake inhibition of serotonin than the norepinephrine. Milnacipran causes more of norepinephrine than serotonin, and TCS does so. Okay, so TCS can be used. Though what happens? TCS are old drugs, so no company is there to back TCS to research on it. Okay, so they are not that popular, but they have done the research. They are new medications, so and they got approval from the FDA. So duloxetine is an antidepressant. It is used to treat the depression. It is also used to treat the pain caused by the complication or diabetic patient caused by the fibromyalgia. Side effects. What are the common side effects of duloxetine? Two side effects we commonly encounter. One is the sedation, and another is the GI side effect. And third one is sometimes palpitation. Okay. So these are the common side effects like diarrhea, vomiting, unusual bleeding or bruising. That is not very common, but diarrhea, vomiting is quite common. Sometimes patient complains of dizziness, sometimes complains of palpitation, and definitely increased sleep. Sleep is a very common to find. Okay, milnacipran. So that is another medication that is approved in 2009 as a fibromyalgia treatment. It is again an antidepressant and it has also good result. Though nowadays it is not available in India market, there is the levo molecule, that means levomilnacipran. Okay, that is available. So here, oh, I have not forgot to say the doses. Now, already I have told the dose of pregabalin, but I have not told the dose of duloxetine. Duloxetine starting dose is usually 20 milligram, and gradually you can increase the dose up to 60 milligram. But in some patients, do we start with a lower dose 10 milligram tablet? Though only few companies have the 10 milligram tablet prescription. But for the first week of 10 days, you can start with the 10 milligram tablet. Then the patient compliance is comparatively better. Then you can go for the 20 milligram tablet. Okay. Or you can do that. You can take a half tablet for first week. Then you can go for the full tablet, as 10 milligram tablet is not usually available in most of the stores. But they are present. Okay. At least 9-10 companies are there. They make this 10 milligram tablet of duloxetine. And milnacipran, I am not talking anymore for the milnacipran, which was dose is 25 milligram and gradually increased up to 100 milligram, but it is not available now. So what we have is the levomilnacipran. Levomilnacipran, we usually start with the 20 milligram dose, and usually we can go up to 80 milligram of dose, but that is not usually required. Usually up to 40 milligram is good enough for this. Now, side effects, again, almost similar: nausea, headache, constipation, dizziness, insomnia, hot flash. So these might occur. Okay, they are maybe this is common for the all antidepressants, that impairment of the sexual function, including both decrease in sexual desire and ability, pain and swelling in the testicles in man, as well as the men that might occur. Okay, and these are the other things when in resistance cases you can go for. One is the systemic desensitization with NMDA receptor antagonist, IV lignocaine, and you can go for the trigger point injection in some patients as well. These are the ways that you might need to do. So that's almost. So any question?
Regarding the dose NMDA receptor antagonist, ketamine.
Okay, the ketamine is not usually prescribed, but if you want for systemic desensitization, usually 100 milligram of ketamine, which is actually mixed in a bottle. Okay, I think Sir can tell better. I have not done much of the systemic desensitization, but Sir has done many cases, I think. So, sir, can you tell me about them about systemic desensitization, as I have not used it much?
Yes. So fibromyalgia patients who are not responding to the usual drug, fibromyalgia, the two most commonly prescribed drug is your pregabalin and duloxetine. They are the two drugs. Sometimes we use alone, but if the symptoms are very severe, you can combine these two, means pregabalin and duloxetine. And some company has the combination also. But otherwise, these two drugs are the most effective drug and most commonly used drug. Now, if the patient is not having the good relief with the duloxetine and the pregabalin, and even if you have added some tramadol or this kind of medication, still not having good relief, even increasing the dose, these are the candidates for the systemic desensitization. So systemic desensitization should be done. The basic primary drug is your lignocaine. Lignocaine must be there. Along with lignocaine, you may add ketamine. Then the results are still better. So lignocaine dose is 3 to 5 milligram per kg body weight, and that to be transfused over a period of 1 to 2 hours. So it should not be faster than 1 hour. It should not be slower than 2 hours or 1.5 hours. I normally transfuse it between the 1 hour, 10-15 minutes. Then the blood level will be nicely reached. And you can add ketamine there. Ketamine added, the dose ranges from 25 to 50, but up to 100 milligram you can give. But most commonly we give 25 to 50 milligram. And again, mixing up with the same syringe pump. Means syringe pump, we are taking the lignocaine, means 3 to 5 milligram per kg body weight. Along with that, a little bit of ketamine. And adding ketamine have the benefit that the pain relief is better. But again, some of the other delirium and other part of the ketamine has to be taken care. Okay, and it has to be given either daily or alternative day for 5 to 7 such sessions. And with that, it is seen that the patient is having the good and adequate pain relief with this regime. And after that, you need to continue the other drugs. It is not that you will be stopping the other drugs. Then that means pregabalin, duloxetine, this kind of drugs to be continued. Okay, is it clear?
Okay, sir. Thank you, sir.
Sir, is there any complication regarding this treatment?
You have to monitor it, because you all know lignocaine has a lot of complications, particularly the arrhythmias, heart block, bradyarrhythmias. So it has to be done under the cardiovascular monitoring, means ECG monitoring, and your pulse oximeter must be there. So without this cardiovascular monitoring, you cannot do it in the OPD basis or at home care basis. You have to admit the patient for as a daycare. You complete the drug. Even after completing, patient will be having some drowsiness. So keep the patient admitted for another 1 hour, and then you discharge the patient. Okay.
Can it be repeated, sir?
I told you already. Normally, daily or alternate day has to be given 5 to 7 sessions, and other medications should be continued. Now, what is seen after this one means 7 times in one time you are given in a week or 2 weeks. After that, patient enjoys the good pain relief with the other drugs, and that normally continues for approximately around 6 months or something like that. When the pain will be again increasing, then you can again repeat the same around 5 sessions. But normally, repetitions is not needed before 3 to 6 months. Okay, so Kanchan is going to present Kahoot, one Kahoot now.
No, it's me.
No, sir, it will be Devjyoti boss. He'll be taking.
Oh, Devjyoti, okay, fine.
Already pain is there.
Yeah, yes. Yeah, we can see. Sir, after this Kahoot, it will be your lecture.
Okay.
Still, I think around 13 have not joined.
Yes, sir.
Requesting all to join.
Still, some people has not joined. I don't know whether are they unable to join or only 45. As we already told, this is the last chance to have a rehearsal before the final one.
And some question might come from this as well.
Should I stop recording?
Yes.
I love to tell stories, I'll not be bombarding with a lot of information. I'll be just telling stories so that you are getting inspired and you will be reading more, right? So reading materials will be shared. I'll be talking about myofascial pain syndrome. So you can understand from the name, myofascial pain syndrome means the pain coming from the muscle. And if you are looking back about the anatomy of the muscles, skeletal muscles, I'm talking about the myofascial pain comes from the skeletal muscle, not from the smooth muscles. And if you are reading the anatomy, then you'll be seeing that the nociceptive fibers are very rare, very few in the muscle. So this is one of the very important question. It's a very important, the dilemma that muscle pain, myofascial pain actually travels by which pathway. But still now, this question mark is there. Please, answer is not solved. It is still thought that it is the same spinothalamic tract through which this pain also is going. So what exactly happens in myofascial pain? Again, we are in dark. But we know what happens, what are the effects. How it happens, we don't know. But what happens, that we know. So what happens in the myofascial pain? Normal muscle, if you are pricking a needle, all of you are, most of you are anesthesiologists. Suppose you are doing a regional anesthesia. What has been there in the book? Raise a skin wheel before doing the procedure. Nowhere it is written that you also infiltrate the local anesthetic in the deeper structures. That is not needed. Why? Because in the muscle layer, when you are pricking the needle, when you are passing the needle, the pain is not much. Pain is maximum when you are pricking the needle at the skin, subcutaneous skin area. So that means muscle, normal muscle, if we are pricking, if we are cutting, not much of pain. But if it is sensitized, then it will have the pain. So now how it is getting sensitized, again, lot of hypotheses are there. I'm not going into all those hypotheses. You can read the books and see what are the different hypotheses. But what happens in myofascial pain, there are certain hyper irritable area, and that is called trigger zone, trigger point. So in that hyper irritable area, if you are pressing, if you are pricking needle, if you are cutting, patient will jump in pain. That means not the whole of the muscle. In certain small area of a muscle that is becoming hyper irritable, and that is called a trigger point. And in that hyper irritable area, if you're pricking a needle, then patient will feel pain. So what happens in that area? There is a contractile myofibrils, muscle fibrils. They get contracted at that area, and from that area, the pain signals generate. So this is what is your myofascial pain. And if you're stretching that contractile band, then the same kind of pain will be reproduced. So this is the pathognomonic. Remember it. So number one is there will be presence of an hyper irritable area called the trigger point or trigger zone. And second is there will be contractile band. And if you're stretching that contracted band, the pain will be reproduced. Right? So this is what is myofascial pain. And if you are pressing there in that trigger point, patient will jump in pain. And that is not called jump sign. No, this is one of my very favorite questions. That what is jump sign? Who will jump if you are putting it there? Doctor will jump, or the patient will jump, or the muscle will jump. Who jumps in jump sign? So it is the muscle which jumps. That means contracts. So this contraction of the muscle is called jump sign. So when you are pressing there or pricking a needle, that contractile band will be contracting further, and that will be visible contraction, and that is called jump sign. So nobody jumps. Muscle in that area only jumps. So what I told, one is trigger point. Second is contracted muscle. Third is jump sign. So with these we have to diagnose, make a diagnosis. So I'll be coming to the trigger point now. So what is the trigger point? As I told, a hyper irritable sensitized area of a muscle, of a skeletal muscles areas, that is called trigger point. And if you're pressing there, you might be getting jump sign, as well as the same pain will be elicited. And pain might be referred distally. So if the pain is referred distally, then that is called an active trigger point. And if the pain is felt only that point, similar to that of the elicitation of the tenderness, then it is called a latent trigger point. And where to search for this trigger point? In the bulk or belly of the muscle, not at the origin or insertion point. So this is one of the very important differential points, that where the tender point is situated and where the trigger point is situated. Like Dr. Devjyoti just now covered the myofascial pain and fibromyalgia, and where he was discussing about the tender points. So there are 12 tender points, 18, sorry. Nowadays tender points and elicitation is not done. 18 are there. So there should be at least 12, 11 or 12 trigger points, tender points to make a diagnosis. So what is the difference between the tender point and the trigger point? Tender point is situated at the myotendinous junction or at the origin or the insertion of the skeletal muscle. Tender points, if you are pressing, pain will not going to radiate distally. Whereas a trigger point, it will be on the bulk or belly of the muscle, and if it is an active trigger point, then it will be radiating distally. If it is a latent trigger point, pain will be locally. Then how to differentiate between a tender point and a latent trigger point? Because both are eliciting the tenderness, no radiation. So that should be differentiated looking at the whether it is at the bulk or belly of the muscle or whether it is at the origin or insertion points. If it is at the origin or insertion points, then this is called tender point, right? So, and second thing is, if you're stretching the muscle, pain will be elicited and there will be jumps. And this is how the trigger point is basically diagnosed. What is the management? Management is trigger point neutralization. So you are neutralizing trigger point. How? Physiotherapists do it by manual neutralization of the trigger point. But we pain physicians, normally, we prefer to go for the trigger point injection. So trigger point injection, how it is done? You have to, hold the muscle bulk with the two finger, with your this thumb and index finger, hold it, and then you prick the needle in a fan-shaped manner. You put it, and then in the fan-shaped manner in the different direction, you inject local anesthetic. Or just do a dry needling. Put the needle and the fan-shaped and keep it for some time. That is called dry needling. Dry needling is also a method of trigger point neutralization. And very rarely we can give a very small dose of steroid. Steroid is contraindicated in the bulk or the belly of the muscles. Small dose can be given. Repeated steroid is basically contraindicated. Why? Because it can cause the muscle fibrosis. So the muscle, what is the basic feature? It is stretchable, contractile. And if you are giving repeated steroid, what will happen? There will be fibrosis. And this contractile feature of the skeletal muscle will be lost. 1 or 2 doses can be given. Very small amount of the steroid is given. But otherwise, normally we avoid giving steroid injection in the trigger points. And extremely rarely it can be cut. When particularly because there is a contraction and there is a nerve nearby. And nerve is getting entrapped because of the myofascial pain. Then sometimes in a refractory cases, sometimes the muscle is dissected so that the nerves becomes free. So this can happen in one of the very common area of the myofascial pain is your piriformis syndrome. Okay, so up to this, is it clear? If you have any questions, you can ask me. Now I'll be going 2-3 trigger myofascial pain like the piriformis syndrome, psoas quadratus myofascial pain syndrome, and trapezius. These are the few very common myofascial pain syndrome. I'll be talking about this myofascial pain syndrome in short, briefly. But before that, if you have any confusion regarding what is myofascial pain syndrome is a very common. Okay, I forgot to mention one important thing, that what is the pathophysiology, why it happens? Mostly it happens because of the repetitive stage injury. Suppose you are whole time sitting on the same posture, drilling forward, or you are working in the computer, hanging hands, so the trapezius muscles are stretched continuously. This is one etiology. Second important etiology is if there is a tear of certain muscle fibers. You are stretching something to pick up, and you are stretching too much, and one or few muscle fibers there is a tear. So that is also a possibility. And third possibility, if the patient is having other chronic illness or other illness, say for example, somebody has a myocardial infarction, somebody is having the appendicitis, somebody is sitting long time in front of the AC is behind you. So all this, what happens? There is a muscle contraction. Why? This is an reactive phenomenon in response to the cold, in response to the other pathophysiology like the appendicitis or myocardial infarction. There is a contraction of the muscle, and then what will happen? That contraction of the muscle, if it lasts for a longer time, so there will be a development of the sensitized area. So these are the few etiologies why it can happen. So let me repeat. One is repetitive stress injury. One is chronic illness, like as I told you, chronic appendicitis, any other chronic. Suppose somebody is having the facet joint arthritis, sacroiliac joint arthritis, or acute illness like myocardial infarction or acute appendicitis. So these are the conditions where somebody is having the chronic depression can also have the myofascial. So the muscles will be contracted for the longer time. So basic pathophysiology here is muscle remains contracted for the longer time, and then the hyper irritable sensitized zone might be developing there. So this is the etiology. Pathophysiology, I told you that it is not clearly understood, but there is some way, there is sensitization in that areas. Now I'll be coming to the few points as I told you. If you have any questions, quickly ask me. Otherwise, I'll be talking. One of them is a trapezius. Trapezius is a very common. Most commonly it happens to the computer worker whole day working in front of the computer. These muscles and shoulders are hanging, and there might be development of that. So what will happen? How to diagnose? You'll be getting the local tender or trigger point, or if you're stretching the trapezius, like suppose this side. So if you are stretching the opposite side diagonally, you're stretching the muscles, then your pain will be elicited. Why? As I told you, there will be contracted band, and if you're stretching that contracted band, the pain will be elicited. Treatment is same. You go for the trigger point injection. Piriformis syndrome is one which is very important. Why? Because it can mimic radicular pain. So just in front of the piriformis muscle, what is there? Sciatic nerve. So piriformis, what is the origin? Lateral border of the sacrum, S2, 3 mostly. And where is the insertion? Greater trochanter. So piriformis is an external rotator and abductor. And just in front of the piriformis muscle is your sciatic nerve. And sciatic nerve sometimes goes through the piriformis, or sometimes the tibial part can be going, or common peroneal can be going through it. So it divides early, and one branch might be going through it. So what will happen? If the piriformis myofascial pain, piriformis will be contracted, so that will be producing pressure on the sciatic nerve. So patient will be having the radiating pain. Like in the trapezius myofascial pain, which nerves might be entrapped? The dorsal scapular nerve, spinal accessory nerves. This nerve might be entrapped in the trapezius myofascial pain. Same way, in the piriformis myofascial pain, your sciatic nerve or branch of it might be entrapped. So what will happen? Patient will be having pseudo sciatica. Pseudo sciatica, it mimics closely with the sciatica. Like pain is radiating down and having the SLR positive and other things positive. So you have to keep in mind differential diagnosis. How to rule out? By ruling out the MRI, other pathologies, and by doing a piriformis injection. You give the local anesthetic trigger point injection in the piriformis. If the pain is relieved, your diagnosis is confirmed. So this is piriformis. Then comes is your in the lumbar plexus. Anterior boundary of the lumbar plexus is psoas muscle. You remember the psoas muscle? Vertebral body, lumbar vertebral body. That is the origin, and getting inserted into the lesser trochanter of the femur. So it is an flexor of the hip and pelvis. So what will happen? If there is a piriformis muscle just in front of the psoas, there is your lumbar plexus. So if the psoas is getting contracted, what will happen? Patient will be sitting in front, leaning front. That will be comfortable posture. Why? Because psoas is an adductor. It causes the flexion of the pelvis and the hip. So patient will be comfortable on sitting, leaning forward. If you are stretching, standing, pain will be aggravated. Psoas is a deep muscle, sometimes difficult to palpate, but still deep palpation you might be able to elicit. But stretching means if you're doing extension, then psoas will be stretched and patient same kind of pain might be aggravated. So sitting will be comfortable, extension will be reproducing the pain. And for the quadratus lumborum, it is the posterior boundary of the lumbar plexus. So origin, the transverse process and the 12th rib. Insertion, iliac crest. It is the extensor. So it causes the extension and the lateral bending of the spine. So what will be the posture of the patient? Patient will be tilted on one side, and sitting will be painful. Why? Because when you are sitting, our quadratus lumborum muscle is stretched. So pain will be reproduced. So how to make a diagnosis? Ask the patient to flex forward, patient pain will be aggravated. And you will be able to elicit the tender point or trigger point. Why? Because it is little bit superficial than the psoas. And finally, diagnosis confirmation should be done in both situations by trigger point injection. This is also important. Why? This also can mimic radiculopathy, pseudo-radicular pain. Why? Because the contraction of this muscle can cause the contraction of the pressure, entrapment of some of the fibers of in your lumbar plexus. So patient might be having the radiating leg pain. And we have to come from the diagnosis. MRI will not be matching with your diagnosis. Many times MRI remains asymptomatic. Patient's pain is on the right side and your MRI findings on the left side, or not matching with the level. So always remember that these are the other myofascial pain you have to rule out. before coming to the diagnosis of radiculopathy or radicular pain. These are all causing the pseudoradicular pain or pseudosciatica. So treatment is easy. You have to go for the trigger point injection. And if the nerve is entrapped, then you can, along with the trigger point injection, you can do a hydrodissection of the entrapped nerve. That will be giving a better result. Right? So this is your myofascial pain syndrome. Any questions regarding it?
Sir, how much volume of the local anesthetic we give in trigger point injection?
Normally, per trigger point injection, we give around 1 to 2 cc. As I told you, local anesthetic is not important. It is the pricking is important. And that is the reason why without injecting anything also, dry needling can help. So how, if you're asking how dry needling is helping, again, it's a mystery. So again, the postulation is, if you're doing the trigger point injection, you are basically releasing some of the chemicals, which might be reverting back the sensitized zones. And second important possibility of how it works might be your, the nerve entrapped nerves might be released. So there are the two possible hypotheses how the trigger point injection helps. So addition of the local anesthetic or addition of the steroids is optional, not needed mostly. Just dry needling is enough in most situations. But even still, you used to give local anesthetic, no upper limit. You can give larger dose, but steroid we give cautiously. Don't repeat steroid too much, and give steroid maximum dose of 5 milligram to 8 milligram per trigger point steroid dose, milligram of triamcinolone or dipomethylprednisolone. So per trigger point, 5 to 8 milligram is the dose. Give very small dose and don't repeat it too often. Maximum 1 or very rarely each second. Don't go too often. There will be muscle fibrosis. Contractility will be lost.
Sir,
Yes.
sir, how to identify the trigger points?
I told you, patient will be showing the pain area. And now with your palm of the finger, you palpate, you roll the muscle band, you will be getting that the muscle is contracted, you'll be getting it, and you will press with your thumb, and patient will be jump.
Okay, sir.
So, and also there will be jumping of the local muscle, contracted muscle, that is called jump sign.
Okay.
Right?
Thank you, sir.
But most important is patient will be showing the area of the pain. That is the first indication. Hard to palpate. Anybody else with any questions?
Hello, sir. Sir, what will be the differential diagnosis for this? Anything we need to rule out?
I just told few of the differential diagnosis. Like as I told you, if it is a piriformis, it will be very important. Differential diagnosis will be your radicular pain, disc prolapse.
Radicular pain, disc prolapse.
It can be also mimicking the SI joint pain. It can be your facet joint pain. That means it depends on location. If it is a psoas quadratus, again it can be mimicking your the disc prolapse. If it is a cervical trapezius, then it can differential diagnosis will be discogenic neck pain. It can be facet joint. It can be disc prolapse. So they are the other common things which should be ruled out. Right?
Sir, any muscle can get involved.
Any skeletal muscle can get involved.
Yes, sir.
But these
Yes,
are
sir.
these are the few things that as I told you, these are the few common things. But any skeletal muscles can be involved.
Sir, please
Okay.
repeat the quadratus lumborum trigger point, sir.
What data is any myofascial pain, if you are imagining, first you remember the original insertion. So transverse process and the 12th rib origin insertion is iliac crest. These are extensor and the lateral, it causes lateral bending. So this pain, what will happen? Patient will be comfortable on extension because they are extensors. And if you are doing the flexions, then what will happen? Your quadratus lumborum will be stressed and the pain will be reproduced. So sitting will be difficult for this patient. And extension will be comfortable. If you're asking the patient to be lean forward, pain will be reproduced. And because the quadratus lumborum muscle is not that too deep, you will be so difficult to elicit the trigger point. But quadratus easier. And final confirmation by the trigger point injection. Okay?
Thank you, sir.
Sir, any role of physiotherapy to prevent?
I already told you. What I told, role of physiotherapy. Physiotherapist can also do the manual trigger point utilization with the fingers.
Okay.
And they can also give the stretching exercise because there might be recurrence. To prevent the recurrence, muscle is contracted. No, so what you need to do? You need to stretch the muscle gradually. So the stretching exercises and trigger point, manual trigger point injections. These are the very important, the therapy from a physiotherapist.
Sir, sometimes when we are planning for trigger point injections and while palpating, as you said, the manual movement relieves the pain after few seconds or minutes. Then it's difficult to localize the same trigger point. So should we go ahead with the injection in that case?
If you have already with your fingers, you have neutralized the trigger points and you are not able to elicit, don't go. If you don't able, this is very important things. If you are unable to elicit the trigger point, don't go for the injection. This patient do not need.
No,
Right?
earlier it was there, like when
That
we
means you have
palpated, yes.
neutralized with your palpations.
Yes.
So don't
yes.
go for that. Don't go for that. Why?
Okay. Thank you, sir.
Okay, Kanchan, who is there next? Kahoot or Chinmoy?
Yes, it's Kahoot. And
Okay.
those who are interested in learning USG guided trigger point, I will be sharing you an article. Go through it. It's a very superb article on trigger point injection, ultrasound guided. So sir, I'll be conducting Kahoot now on knee joint.
Okay.
So today I'll be discussing on the practical aspects related to the PRP. Though if you find the studies, if you search the books, there are a lot of theoretical aspects, but no one tells how to make the PRP, how to use these kits, and how to use it for the patient. So what are the ways you can make PRP in your clinic or your hospital, and you can successfully do PRP therapies. Though the number of evidences every day is increasing, the newer studies are coming, even though there is no medical, pharmacological, or whatever you call, the companies to back it. But still, the popularity is increasing by its own. Now coming to the learning objective, to share the clinical experience and practical problem faced during PRP therapy, to share the steps to overcome those problems. So that is the learning objective for today's class. Coming to which patients are suitable for the PRP therapy. So the conditions where the PRP is successfully used are osteoarthritis, tendon healing, muscle healing, articular cartilage repair, Achilles tendon repair, anterior cruciate ligament tear, rotator cuff repair, and subacromial compression, or you can say it, impingement also. Okay, so in those areas, till date PRP is successfully used depending on the variability. The evidence, if you see more evidence in which areas, they are in the tendonitis. The evidence is maximum. And they have successfully used in those conditions. Now, how PRP works, the true fact is we do not know the exact mechanism by which PRP works at these areas, but these are the growth factors that are present in PRP and that are believed to work for the repairing or healing of the affected tissues. There is no cellular element, but there are platelets. So what we have platelet-derived growth factor, transforming growth factor beta 1, basic fibroblast growth factor, vascular endothelial growth factor, epidermal growth factor, hepatocyte growth factor, insulin-like growth factor 1. So these are the growth factors that are believed to do the healing for you, for your patient. Now, is PRP safe? The question might come, as because it's a newer form of therapy and it is not well approved like other therapies. Nowadays, there are a lot of studies, okay? Lot of review studies are also there. Most are in favor of PRP, but definitely some negative studies are also there. But one thing in all those studies, it is clear that PRP is safe. There is no major problem if you are preparing definitely from the autologous blood. Theoretically, there is minimal risk of disease transmission because you are taking the same blood from the patient. So there is no such chance of disease transmission if it doesn't accidentally change with something or someone. That's a different issue. And minimal chance of immunologic reaction. So in that part, PRP is safe. Now, then where is the chance of risk? Chance of infection. Okay. If you are injecting, we are taking out the PRP, and serum is a good culture media, then you are preparing. So if it is infected, then their problem can occur. So there is chance of infection from contamination and injury to the nerves or blood vessels while injecting the PRP. So how it can be basically avoided. So how to overcome these problems? Okay. So to reduce the chance of infection, used in a closed sterile method and use it freshly. Okay, so that there is no chance of bacteria growing inside, and use closed kits. And if required, you give antibiotic prophylaxis for the patient or post-procedure antibiotic for 3, 4, and 5 days. Now, to avoid the injury to the related structures where you can want to give, you routinely use the musculoskeletal ultrasound that we have learned and you are learning also, and put PRP at the target. So it requires some time to learn ultrasound. Definitely, we have experienced in these last 3 months that ultrasounds require a little bit more learning than CRM or any other simple things, because here you need to know everything and you have to be acquainted with the views what we see in the ultrasound. It is not the X-ray like view or MRI like view. Here the view is slightly different. Okay, so it is like a torch. It is a beam, flat beam type of thing. So you need practice, you require skill, and that requires a little bit time to master. Now coming to the one of the major problem, role of insurance. Yes, till date, PRP, most of the insurance are not covered. Okay, that is a big problem. So you cannot bill it, and chances of reimbursement if you are doing PRP is very, very less. In India, OPD, it is a OPD procedure. In India, OPD procedures are not mostly covered except if you come for corporate insurances. So chance of getting insurance covered with the platelet-rich plasma therapy is really low. So that's a problem. Now, investigations to be done before PRP injection. I think you need to know that the patient is having adequate platelet count and the patient is not having any serious infection in blood. The coagulation profile is normal. For that, we require fasting BP, CBS. Fasting BP is also important because the antibiotic prophylaxis, if the patient is having high blood sugar, you should be more careful for those patients. CBC, FBS, PPBS, CRP to know the inflammatory markers present or not, VTCT, creatinine, USG, MRI examination of the site. These are the routine investigations we usually ask for those patients before doing PRP. Now, coming to the common preparation methods. Okay. When PRP newly came, and I was really thinking that time we have not started PRP. How to start PRP? We have seen some articles, we have seen some journals, and one of the another pain physician from Kolkata, he asked me that he has started with a very simple method, taking two sterilized test tube and putting the blood there and then centrifuging it and then taking out the, from the middle layer, taking out the PRP. But these open methods have the serious disadvantage of contamination. Okay? Because it's an open tube and you are sterilizing, you are not sure whether the sterilization is proper or not. So that might cause problem. Next, another set of physicians who were attached to the hospitals. So they have an easy access to the hospital blood bank and they have all the facilities. So what they do, they send the patient for a blood donation and from there they take a bag of PRP, okay, for the autologous PRP for the patient. Very simple, no requirement of any staff training because all are available, okay, in the blood bank. So that way it is very easy for them. Okay. So what are the advantages or disadvantages of that? First of all, it is very cheap because all the structures are there, okay. Use of existing infrastructure. Next, staffs are already trained, so there doesn't require much of training, so minimal training required for the staffs. But disadvantage that you are sending the patient to the blood bank, so it requires a time, okay, and then depending on the cooperation from the blood bank staffs, okay. So if the patient having very loaded blood bank that day, they might not be happy to categorize 4 or 5 patients, okay. So that is one problem. More chance of contamination. So they are handling together a lot of blood bags. The chance of contamination is also more. Not suitable for small clinics. Okay, if you are running a small clinic, your own clinic, then it is very difficult for you. And more than required volume is processed. So what they have, they produce at least a small bag of PRP and they will send it in a bag. So it does more than required volume. Okay, this is the PRP obtained from the blood bank. So when I was working in one of the medical colleges in Kolkata, that is the Arjikar Medical College, from where I have done my fellowship also in pain. So there we used to do like that. We send the patient, we prepare the patient before, we do all the tests, send the patient to the blood bank, and then from the blood bank, they draws the blood and they sends the PRP bags like this to our hotel. Then we used to give the PRP to the patients. Okay, so that is how we used to do in this setup. But you know the advantages and disadvantages now. Now, open method that I have told that I have learned that from one of the physicians from Kolkata who started fast the PRP therapy in Kolkata. So it is using the ACD. You have to collect the ACD, you have to keep it sterile, conventional test tube and centrifuge. You can use the single and double spin criteria. So it is like this. Okay. So what we used to do, this is the open centrifuge tube. Okay. So this is done by me actually, lot time back in a very peripheral city in near Kolkata. So where this is sterilized centrifuge tube, and then we draw the blood, put the blood here, then we mostly do the double centrifuge, and then we take the Bafikot and some amount of plasma. So advantage is that it is cheap, minimal cost, because everything is easily found and it is very cheap. Consumes considerably more time compared to the commercial kits. Okay, that is not the advantage. Basically, this is the disadvantage accidentally written here. Now, disadvantage is more chance of contamination. Okay, sometimes transferring blood product from one tube to another is difficult. So all pipette and everything you have to keep sterile. It is difficult. Staff need to be trained and it is difficult. No temperature control can be achieved here. There is no chance of the temperature control as it is open tube. So that is the advantage. Disadvantage. Even today I do not do this. Next is the closed tube using acid tube commercially available. So we have commercially available acid tubes like this. And these are the kits that can be purchased from different online sites or in your city from the shops who sell this actually. So here you have this collecting tube, you have this disposable sterile needles, you have this sterilized acid tubes. So first of all, These kits needs to be purchased separately. Okay. So closed kit, less chance of contamination. That is definitely advantage because it is a sealed acidic tube, sterilized acidic tube. Cheap and takes less time, only 15 minutes. Tube is already filled with the acidic solution, so there is no, don't have to keep the sterile acidic solution, you don't have to add the acidic solution. You have a pre-filled tube. Good for small volume, usually 8.5 ml. There's 4 to 8 tubes for sufficient volume. If you are going for the knee, or especially both the knees, then you require a lot of tubes. Okay. Disadvantage: disposable kits for every procedure adds the cost. If you compare with the open method, okay, no temperature control, tube, needle, phlebotomy equipment to be purchased separately. It doesn't come as a commercial kit; it comes separately. Okay. Difficult to draw PRP and RBC are not completely separated by the gel layer. So what it is in comparison with the commercial kit with gel, what is available here, it is not separated. But today, even today, we use this procedure. It's comparatively easier, cheaper method. Okay. And blood collection, comparatively difficult if you think of this PRP kits. Next, coming to the this refilled kits with the gels. So this is how the PRP kits are available. So they have all the equipments what you need for the PRP preparation. So what is there? These are the acidic tubes with the gel. So what is the advantage of this gel? We put the blood here, okay, and blood is collected with this closed tube. Okay, put this inside the patient veins and we just place it inside. So blood will be collected till the brim, and now you just shake it so that this acidic solution mixes with it, and then do the centrifuging. Okay, after centrifuging, what happens in the lower portion below the gel collects the blood. Then lies the Buffy coat and the PRP above. So you can easily collect it from this interface and the RBCs do not come. Okay, that is so easy. And needles are also available, these long needles you can enter and you can draw. Okay, so that is very simple technique. Now coming to its advantage and disadvantage. Closed kit, less chance of contamination, easy, fast, only 15 minutes to get the PRP. Tube prefilled with the gel and with the acidic solution. Okay, easy to draw PRP and RBCs are completely separated by the gel layer. Here is intervening gel layer. So what happens? It is easy to draw. There is no chance of RBC coming inside your syringe compared to this method. But they are not separated. Okay, if you shake it, they might get mixed as well. Disposable kits are for every procedure adds to the cost, no temperature control here. Now, these closed tubes. These are comparatively costlier kits. They have a special hourglass-like construction. So what is there? There we have this side of tubes, and in this outer tube we usually put the blood. And now after the centrifuge, they collect in the central tube at this place. And through this central opening, we collect this is the pouring of the blood. You are first putting in the outer tube, and then you have to press this. Okay, you have to screw this lower portion to get the PRP layer actually here at this place. And you have an opening here. Through that, with a small syringe, 2cc syringe, you first draw the PRP, then you mix with some amount of plasma. So that is the advantage. So closed kit, less chance of contamination, easy. It is even faster. It requires only 3 to 4 minutes. Easy to draw. PRP and RBC are separated by hourglass design of the equipment. 30 ml blood volume can be centrifuged with a single equipment. Disadvantage is that disposable kits for every procedure adds to the cost. Temperature control present, that is the advantage. Some advantage and disadvantage are actually got mixed. Next, kits are costly, SD not prefilled and needs to be added separately. That's the disadvantage here. It doesn't come prefilled with acidic tube. So that is another technique, but the cost of this equipment is comparatively higher. So nowadays we are using mostly these two techniques, this one and this one. Okay. So that is the advantage or disadvantage of this tube. Though we have used this kit for a lot. Now, what volume of PRP is required for different procedure? To be frankly say that these volumes are never written very clearly in any book or anywhere, but this is from the experience what is actually required in those conditions. Okay, for the osteoarthritis knee, use approximately 5 to 6 ml per knee is required. Tendon healing 2 to 3 ml depends on the tendon injured. Muscle healing again depends on the muscle injured and it is usually 2 to 3 ml. Articular cartilage repair usually 3 to 5 ml. Achilles tendon usually 3 ml. Anterior cruciate ligament 3 to 4 ml. Rotator cuff repair depends on the number and of 10 tear and usually 2 to 3 ml at one area. Subacromial decompression 2 to 3 ml, shoulder joint usually 5 to 6 ml. So that is how volume is usually injected. Now, what are the common post-injection problems? First of all, pain at the injection site, that is the very common. Use paracetamol, opioid, ice compression for that. Acute inflammatory reaction, common, use paracetamol, opioid, and usually NSAIDs and steroids are avoided because PRP is pro-inflammatory. These are actually anti-inflammatory. So usually anti-inflammatory agents are discouraged. And ice compression. Okay. So paracetamol, opioid, and ice compression, that's three things we can use. Infection is comparatively rare condition to be diagnosed and treated early. Use of aseptic technique, check the CRP, use of antibiotics as required. Now coming to the limitations. Though in different studies, PRP has shown its benefit, but the problem is the composition of PRP varies from patient to patient and may also vary from device used to prepare it. So the standardization, I have told you so many processes and so many things, what is common, what we are using, everything. But there is no standard method like a drug when it is prepared 500 milligram paracetamol. So the standardization that is done is lacking here. So there might be a variation in composition. The time and method of storage until used and whether it interacts with the other biologics or materials, these parts also needs to be researched. Due to these inherent inconsistencies, result might be inconsistent. So that is one of the biggest problem in PRP. In some patients, you do PRP and you are so happy that you want to do PRP in all patients. Okay. So the patient is so happy. You are also happy definitely when the patient is happy. Patient is telling I have no pain. You are also happy. But that doesn't happen all the time. So you have to explain the patient all the things about the PRP. Don't hide anything. And then ask the patient to decide. PRP can lead to the fibrous connective tissue and scar formation. So that is one possibility. So these are the limitations of the PRP therapy. Now, important practical tips. First of all, as I have told, never promise, claim medical or magical medical cure for the patient. Okay, so nothing magical is going to happen. Though in some patient you will be surprised at how it is working so good, but you do not claim it because it doesn't happen in all the time. First case you very good, you got very good success, and you are thinking to the next patient, ये तो काम हो जाएगा ही. You can say like that, but there is no chance of that because in the second patient it might fail because of the inconsistencies and things that we till date do not know. Explain all the aspects of the procedure and share the recent scientific data. This is very, very important because this is the day of internet. What you know, what you can search, the patient can search everything like you. Only difference is what you have is the experience the patient do not have. So whatever is there, you are seeing that through your filter of experience, but patient is seeing that without anything. So that is the difference. So whatever is there on the net, whatever is there evidence-based, all explain to the patient that I have told previously as well. Then ask the patient, this is the thing, and you go through these studies and then you decide. Okay. Repeat injection may be required, the best benefit for the PRP, though the guideline is not yet made. Okay. So how many times or after how many times there are a lot of evidences, but still that for every condition, which one is the best is not yet guidelined by anybody. So that is another problem. Okay. But usually what we follow, we do the first injection. If the patient is benefited almost 100%, we never go for the second injection. If the patient is having a partial relief, then we ask the patient to repeat after 3 weeks to after 1 hour. Okay? And it gives a complete healing or almost complete healing, 90% relief from the pain. So that is what we commonly do. And if there is no response, I usually do not repeat for those patients. Okay, though it should have a guideline, but that is lacking till date. Now, final words. PRP was a major initial step to the researchers to dig into more into regenerative medicine. Okay, in the field of pain management. So, what PRP is actually gold mine. More research might find further uses and further advantages of PRP. And if we can standardize the things, if we can go into more details of the science, how the PRP is acting magically for few patients, then definitely it can be a major jump. Remember, steroids is such a thing that was invented long back, and that started an era of steroid almost. Okay, like a coal era or like a petrol or a liquid petroleum era. So till date, see, even for the COVID, ultimately what proven beneficial is steroids. Okay, for the lung protection. So ultimately, it is still going, but this has the potential to start a new era of regenerative therapy. So that's what I believe, and that's what I use the PRPs. So that is almost the final words, and definitely you go for the researches, go for the different techniques, standardizing the things that can be the way forward. So that's all. Thank you. Any questions?
Sir, I want to ask one thing.
Yes.
If we are giving PRP, like for supraspinatus tendinopathy, so should we tell the patient to do the exercises as well, or should we tell him to, do just his routine work or do restrict his work to the?
See, what condition you are telling, that is the supraspinatus tendinitis, you will find this is evidence-based. There is no contraindication for the exercises. Okay. So if it is not possible because of the pain, then it is okay. But otherwise, we never ask the patient or never discourage the exercises. Okay. So ask the patient to do it.
I'll be adding one thing with Debjit's comment. What Debjit told is right. But initially, when the pain is more,
That's why I told the initial for the pain.
So initial 2 days exercise can be avoided, number one. And if there is partial tear, then also exercise should be avoided at the initial phases. But if it is only tendinopathies without tear, then definitely after the initial pain is less, then exercise can be started.
So you mean to say initial phase of pain generally lasts for 2 to 3 days or more?
It varies too much. Normally I always ask the patient that initial increase of pain might be there for around a week, but it varies patient to patient. So, and in my patient, I tell that, okay, initial 7 days, don't do exercise. If the pain is very much reduced in 2-3 days, then you can, because it varies from person to person. But otherwise, don't do exercise till the pain is there.
And actually, in this area, there are studies are a little bit conflicting. Even though actually I used to do this, but one orthopedician told me that you see the evidence. In evidence, it is saying that exercise they have never discontinued. But anyway, there are opposite type of studies are also there. So this area is also not very clear. So definitely more research required. In all of our PRP, definitely more research required
And
to actually standardize the things.
what about sir, ice compressions? I mean, should it be continued? How long should it be continued?
It depends how long the pain is there. Okay. Usually for the first day, we ask for the ice compression, but rarely it is required after that. Okay. Beyond 1 day, it is usually not required.
Thank you, sir.
So regarding osteoarthritis, role of
Yes.
PRP, to which stage, sir? Either they are saying second stage or the third stage.
But I could not get the question. I get the only partial words, few words I can able to hear.
Sir, for osteoarthritis, up to which stage PRP we can use, sir?
Okay, there are the studies where it is shown it is most beneficial in grade 1, 2, and in early cases of 3. But it depends on the patient. Okay, in some patients, even with a grade 4 osteoarthritis and with a meniscal tear, I got benefit. Okay, I can still remember the patient where I said the chances that PRP working is very, very less, but the patient insisted because now PRP is such a thing when patients are reading from the internet and they are coming after reading from the internet. So I taken the consent that though it might not work, but after that it is to my surprise, it worked so beautifully. So again, this area you need more studies.
Okay, sir. So can we repeat second dose also for these kind of patients?
Yes, it can be repeated.
Okay. Okay.
And surprisingly, if first time it works, second time it also works, what I have found.
Okay.
Sir, what will be the RPM for spinning and how much time we should spin it?
It depends on your technique. Okay. So the technique I have told that a double hourglass, they usually centrifuge at 5,000 RPM. But what we commonly do with normal centrifuge, it is something between 1,000 to 3,000 RPM. But there are studies. In this part, there are some studies in how much spinning you start on the net. I have already collected the thing I have there. I can share you too. So they have found out what are the ultimate ideal RPMs. But we do not have RPM set always in the machines, but it is something between usually in normal centrifuges we use the 3001 and with those centrifuges we use 5001.
Sir, is there any benefit of if we inject the WBC rich PRP?
Yes, in this area also, whether it is WBC rich or poor, whether it is the activated platelet or inactivated platelet, or whether we have to use the activators. Okay, now some companies are coming up with the activator kits where you do the PRP and there will be already activator that will be mixed with it. So these things are coming up. So definitely with time, more and more will be unfolded. That's why I've told it's the beginning of an era.
Sir, can we use it for the frozen shoulder also?
Yes, we have used it for the frozen shoulder also. But remember, in frozen shoulder, definitely for the stretching part, it can be used. But in frozen shoulder, if the patient do not do exercise, only PRP will not work. Exercise is must for the frozen shoulder. Even if we stretch with the PRP or even with the saline also. Okay, but exercise needs to be done.
Thank you, sir.
Sir, will it create any problem if some packed cell are mixed with the PRP during the separation?
Some RBCs or platelets, what you are asking. Platelets will definitely be there. WBCs might be there, RBCs. Okay. So again, in this area, the studies are lacking. But I can tell you my experience, it happened. And what I have found, if RBCs are there, the initial inflammation part is much more. Again, these are from experience, these are not from the studies, okay? But the results are also better. I do not know why, but this happened for me in 2-3 cases. But definitely, initial
not only that, there are a few areas like your some of the like osteoarthritis of hip, then your tennis elbow, this kind of areas, the whole blood also have been given, not
Yes.
just separating the platelet. So whole blood also where the RBCs are there, that also gives benefits. So, but what you told, that is very true, that if there are RBCs, then the initial pain increases and that lasts for longer time than if the RBC is separated nicely.
Sir, regarding osteoarthritis of knee, should we inject sonoguided, or we can give blindly through in the interarticular space, or any specific area we should give?
Usually for the osteoarthritis, we give from the suprapatellar pouch. So if it is not possible, sometimes there is no fluid, so identifying it is difficult, then we go for from the lateral or medial recess and definitely with the ultrasound guidance. Otherwise, you might inject inside a tendon or you might inject, and that's large volume. Itself, it can cause the tear of the tendon with the pressure. Okay, not by anything else. So do it under ultrasound.
Sir,
So not
sometimes
only osteoarthritis knee, not only osteoarthritis
All
knee,
areas.
no intervention should be done without any image guidance, either ultrasound or serum. Any interventions, always the thing you have to do under the guidance. Without image guidance, no procedure should be done. Very simple.
So sometimes we see some physician uses steroid with PRP. Is it rational or not, sir?
It is not rational.
We should avoid,
Not
sir.
just
So we
rational,
should-
completely irrational. Completely irrational because steroid suppresses the action. So it is very, very irrational. It must not be used. In fact, steroids should be avoided. If you are planning for the PRP, ask the patient to stop the steroid for some time and then you should be starting the PRP. And don't start steroid immediately after giving the PRP. At least 1 month gap should be there. And if the patient is by any reasons dependent on steroid cannot be stopped. There are certain conditions where steroid cannot be stopped. Then don't do PRP at all. Do for the other modalities. Don't go for the PRP.
So how long NSAID stroke avoidance pre and post injection?
Could not get you. What is the point? How long?
I mean, how many days NSAID should be stopped before injection and can start after how long after injection?
Okay, usually we stop NSAIDs before 7 days of injection, and after, as I was already told, around 1 month, we usually avoid these NSAIDs. We prefer to give only the paracetamol.
regarding
Okay, thank you, sir.
if patient
For
is,
Dr. Kanchan,
Yes.
Dr. Kanchan, if we inject D5% for carpal tunnel syndrome, can we give tramadol as painkiller?
We inject 5% dextrose for what? I couldn't get you that line.
Carpal tunnel syndrome.
Yes. Dextrose.
And then
any problem with tramadol. Tramadol, in fact, you can give after giving PRP also. If the patient is having pain not subsided with paracetamol, then the next thing to go for is tramadol, right? So see what the gist of the story is. I'll tell you in one line. What we are giving PRP, what boss has been telling since long is we are trying to do inflammation. We are trying to create an iatrogenic inflammation over there. So whatsoever thing is just trying to stop that inflammation, we should not be giving. Now, what all can stop? NSAIDs, they work through that prostaglandin cycles. Second, steroid, they are already anti-inflammatory. So if we are going to give something which is just stopping what exactly we are trying to do, should not be given. This is the gist of the whole story. Am I right, sir?
Yes, right. And
very clear, ma'am. Thank you, ma'am.
This proliferative actions of the PRP last for around 1 month, sometimes even more than 1 month. But initial 1 month is important, and that is the reason why 1 month you should not be giving this kind of medications.
And do a proper counseling. That will really solve all your problems. If you will counsel your patient very well, you tell them, then, I'm injecting something maybe you're going to have a pain, excruciating pain. You say it like that so that, they will be like very happy. Oh, madam said excruciating pain. Now I'm not having that much of pain. So you will be having initially a pain, and that will be there for 24 to 48 hours. And after that, maybe the pain intensity will be reducing, something like that. You should explain to the patient. Believe me, this counseling will really help you, because if they will call you up, you can always say, see, I've told you, it will be painful. So you have to bear with that. If it is painful, you take paracetamol, something like that. If you'll explain it before, I think post procedure, all those things will be little, you'll be little relaxed after doing a procedure.
Kanchan
Question
ma'am,
for ma'am.
Madam, what's the post-procedure care, madam? After any intervention, do we supposed to add any antibiotics along with analgesics?
See, antibiotics is not required. You take a proper care of the infection. How can you take care of that? First, rule out any, first thing is like whichsoever area you are trying to do an intervention, there should not be any, pustule over there, or, any kind of abrasion. So that will be a source for that infection. Second thing, properly clean that area with betadine, let it dry. And third thing, do not use that probe directly. I have taught you how to even maintain the sterility of your probe also. So that is the third thing. If and when you are doing a procedure, just before the procedure, fumigate your OT. I do it regularly. Like if I have an OT day, just the one day before, I fumigate the whole OT. So, all these precautions, if you'll take, there is no need to go for any antibiotic. And do not just do an intervention without having a proper apron, wash your hands properly, like how we give a spinal anesthesia. We dress up smartly. So that way, you need to dress up, you need to maintain the sterility. And if you'll maintain that, believe me, the chances of infection will become very, very less. I should say nil. Till my 6 years of my practice, I have not even seen a single case of post-procedure infection with my patients. So this is what I'm very particular about, and you also be very particular about when you are doing an intervention. I hope that answers your question.
Regarding CTS, can we use visco supplementation injection?
Yes, PRP with HA has got good evidence as compared to PRP alone. HA is coming up very nicely now. PRP with HA, it's like you are giving a carrier, something like that, So PRP with HA, how I give PRP. First, I give PRP with HA. Second time, usually I give 3 injections. I tell the patients in the beginning that there'll be 3 injections. I give 1 injection. First will be PRP with HA. Like suppose I'm giving it for ONE, because I'm just telling you, it will be easy for you to understand. PRP with HA, I give it. And that too, so ultrasound guided. I don't give blind injections. Second thing, when I ask the patient to come after a month, 3 to 4 weeks, I tell them, when they return, I assess their pain first. I do not go for the intervention. That time I assess their pain. I ask them what exactly is the, we usually have a paper, right, where we write their NRS scale. If you want, we will share with you, because sir is also having, I'm just following what sir paper is there in sir's hospital. So I have the same paper. So usually we write the NRS scale. And when we are doing an intervention, pre-intervention, you ask them what exactly is the score. Once they come after 3 weeks to 4 weeks, you ask them what exactly is the percentage of relief in their pain which was there when you have before doing that intervention. So this is how you assess. If the patient says, no, I'm just having only, I think 30 to 40%, go for the second injection. Suppose after second injection, approximately, I'm just giving you a rough estimate, like 70%, and the patient says, no, I'm fine. I don't want any more injections. I'm very comfortable. My functional ability has increased. I'm able to sleep in the night. There are nothing, I'm comfortable. There is no need to go for the third injection. So it depends on patient to patient. We cannot just strictly, because there are no recommendations for how to go about giving an injection of PRP. Some study says after a week, some says after 2 weeks, some says after 3 weeks. So you follow whatsoever you are comfortable with. Assess the patient's pain And that is the most important, along with the pain, not only pain, functional ability. Ask the patients to go for quadriceps strengthening exercises. I usually ask them after 1 to 2 weeks, I ask them to go for quadriceps strengthening exercises slowly, isometric exercises. I hope you can just ask your physio friends. They will just tell you a spongy ball and just to press it with the knee. So initially start with the isometric exercises. Great, slowly ask them to go for the strengthening, because if you are just treating your joint, you need to make your muscles which are surrounding that joint also very strong. Otherwise, after some time, again the pain will come. But if your muscles are strong, you are improving upon your joint, so the disease progression will be a little bit slower. So this is from
Madam,
my more practical, what I am just seeing and I'm just doing. Yes, anything else?
Madam, what's the role of steroid injection in joints in rheumatoid arthritis, madam? RA?
Yes, rheumatoid arthritis, because it's obviously an autoimmune disease, and we give, the oral steroids. They are bridging between your DMRDs. So yes, you can go about giving, like supposedly it's in the flare phase. So that time it's always better to go for any effusion is there, go for a local with steroid. Once your disease in the remission phase and still the patient is having a kind of a pain, that time you can go for PRP, but not when the disease is active. This is my personal experience. What sir has to say, sir can also add on if he has seen something different out of that, or he has applied it when there was an active disease. I don't know.
What you told that is right. What you told that is right. That means normally it is an inflammatory condition, so inflammation will be there, and the active rheumatoid arthritis with the active inflammatory arthritis, steroid is the choice. There you have to go for the steroid. But in the chronic rheumatoid arthritis, what happens? The joint is destroyed. Particularly osteoarthritis of the knee is more severe and it takes place more early. So that means even the disease inflammation is controlled with the disease modifying drug, but still this patient's joint is so much damaged, the patient needs to be joint to be replaced. This is very common scenario in rheumatoid arthritis, and the knee joint replacement rate is increased in the in the rheumatoid arthritis patient. So in this group of patients, when the inflammation is under control with disease modifying drug, but the joint is damaged, destroyed, so there the PRP definitely has some role. But active inflammation phase, then PRP is not the choice. So there steroid is the choice.
Thank you, sir.
Okay, any more questions, or we can start the Kahoot?
One
It's
last
last
question,
day
madam.
to ask the questions. No, you can ask. We don't mind answering your questions. I'm more than happy, because that really shows the passion, and you are making me happy by asking questions. Already you have made me feel so bad. So now you're making me happy. So I'm happy to answer your questions. Yes, you can ask.
Want to ask?
Madam, actually, what's the choice of ultrasound machine for doing this?
Ultrasound machine?
Yes,
It depends on your budget.
around 10, madam.
Around 10, see, you have Sonosite, you have G machines, and you have Isaorte. Then now Visconic is also coming up. So it depends, ultrasound machine is like, what exactly you are looking for. Like you are looking for a diagnostic, or you are looking just for a therapeutic. If it is only therapeutic, go for a lower version machine. If you want to use your ultrasound machine for a diagnostic purpose, go for a higher range machine. Higher range machine usually starts from 14 to 15 lakhs, and then they go up to 1 crore. It is not just they're stopping. So initially I would say go for a lower this thing, and once you are acquainted with the therapeutic thing, then I think you should go for a higher version.
Okay, madam. Thank you, madam.
And if you have a big budget, then you can go directly for a higher version.
No, madam, not planning for a high budget. Only for a small budget.
It makes a huge difference.
Yeah.
If you are having a good machine, then working with it is you will be happy working with it.
Yes, sir. Yes, sir. Thank you, sir.
Okay, any more questions, or let's have Kahoot? All questions answered? There was one question. Dibjyoti boss, do you want to answer?
Which question?
I should answer.
Ma'am, please.
Work in Chondro, Malaysia, Patella as well.
Hello.
Yes.
Ma'am, please say within 14 to 15 lakhs, mention any name, please. The ultrasound machine.
You can go for GE and you can go for Sonosite again, the same thing. That we have 3 brands in India. One is your Sonosite, one is your GE, and the other one is Isaute. So out of these 3, you scan. See, I rejected GE, I rejected Sonosite. I bought this Isaute. But my friends, they rejected Isaute and they have gone for GE. So it depends on individual to individual. Whenever you are buying a machine, you scan and you see you are comfortable with it or not.
In this course, you have seen 3 machines. One is Isaute, that is Kanchan used. One, what we previously used, that was the Sonoscape. And in last few classes, what we used is the GE.
Oh, yes, that's a good, I think the best answer. You just see all the pictures and then, you can just decide on your own.
Okay, thank you, ma'am.
Madam, please also say something about centrifuge machine also.
See, centrifuge machine, I usually use the gel-based PRP tubes, and for those gel-based PRP tubes, the 8C plus, that is an automatic version of the centrifuge that is from Remy company, because that is the best in that centrifuge system. So 8C plus will go with those gel tubes. And if those gel tubes are from Pure Cell, and this person is from Coimbatore, and you have a video in Dardia YouTube channel also, because sir is also using the same kit. So if you want to watch, you can watch that video. That is by Dr. Hari. He has just described all the steps how to prepare the PRP with those gel tubes. So I go for I have that gel tubes only.
And how is the cost of that machine?
8C plus will be something around, not very costly. It is very okay, 35,000 something. And that is an automatic version. You just set the RPM and every time it works. And usually for all those gel tubes, it is 3,500 for 15 minutes. That's all. You put the tube and then switch it on, because everything is already set there. And then, after 15 minutes, you take out.
And you are happy and we are happy that
I am happy. I am very happy because I am doing most of my practice. It involves around MSK only.
Not ma'am, like that. I am saying that we are seeing you are cute totally from the last week and we are so happy.
Yeah. Last week, it was horrible. I was feeling so bad actually that, the delivery of the lecture was also because of this time. Okay, can we change the answer in Kahoot for final? Yes, Dr. Krishna, in your final evaluation, you are going to get 60 seconds for one question. There was a question in the chat who asked, let me just see. Dr. Sai Janani. Okay, Dr. Sai, yes, because see, this is a part of your patellofemoral syndrome, we say. And what exactly happened in chondromalacia is like you have the softening of the cartilage, and these people will be more prone for development of your osteoarthritis. And I don't know when, there was one article which I was going through long back, and they have given PRP and they have shown that out of all the conservative management which they have tried, because these people, they need to go for TKR. So if TKR is done at a younger age, it's very horrible, So it's better to go for PRP. And yes, there are papers on it where people have given PRP for this condition in order to prevent the early osteoarthritis, because these people will be more prone for the development of osteoarthritis of the knee. I hope that answers your question. And if you want that article, I will search for it. I must be having it and I will be sending you for sure. Okay.
Hello, ma'am.
Yes.
Ma'am, one question. Ma'am, actually, we have discussed all procedures of pain, even the regenerative medicine and everything. But ma'am, we have not discussed anything about ozone. So is it obsolete now or we are still using? You are still using, or Gautam
I
Das
am
sir and
using
Devanjit
it
sir are
if the
using.
patient is not able to afford the cost of PRP. I go for ozone. I use it. And sir is the one who has started, so I think sir can talk few
No, sir's
words.
chapter I have written. I have already read sir's chapter in that interventional pain management book. He has written one chapter on ozone
Okay,
nucleolysis.
you have read that chapter. Wow, great.
Yes.
I wasn't aware of that.
Sir has one chapter in that.
Okay, sir, are you there?
Yes, I am there. I am listening to your conversation. I see the ozone. Yes, definitely it has some work, but we have to be, the rational, not everywhere. Sometimes ozone in India has different phases. In the middle, everybody was using, in every indication ozone was injected. So that phase has now gone, and now it is more judicial uses of ozone. So we started ozone, in India in 2004. Before us, there was Dr. Kumar who started, and Dr. Kumar is no more with us. So he was a neurosurgeon. So basically, in that way, we started ozone fast in amongst whoever is practicing ozone in 2004. And we also have the first published data from India that was published in international journal. So ozone is very good in the disc prolapse, ozone necrolysis. What you do when you are injecting ozone, it has two important functions. One is anti-inflammatory action, because prolapse disc causes the inflammation of the nerve roots. And second important part is it causes the dehydration of the leaked nucleus pulposus. So because of the dehydration, the nucleus pulposus gets shrinked. So the mechanical pressure on the nerve root is also relieved. So ozone nucleolysis is one of the very important modality. It can be used. Lots of papers are there in support. And if you are selecting the cases judicially, means your nuclear material must be having the adequate water. That is the selection criteria. If you're selecting it nicely, ozone is going to help much in the disc prolapse or the nucleolysis. This is one important area where the ozone is used. And second important area of the ozone is which is called the ozone prolotherapy. Means when you are injecting like the PRP, so PRP is also kind of prolotherapy. You are proliferating the tissue. So the proliferation of the tissue can be done by the several ways, like dextrose injection can be going for the, they can give the proliferation. Same way, ozone also can cause the proliferations. So ozone and dextrose combinations are also used. I use it since long back from 2004, in particular osteoarthritis knee. But ozone and this dextrose combinations can cause the initial inflammation too much. And nowadays we are shifting over the PRP because there is no such big comparative study with the PRP versus ozone. In my experience, what Dr. Kanchan told is same holds good. PRP is a little bit costlier because you are using the costly kits. Ozone is in that way is much economical because you are not using any costly kits. You are just taking ozone from the machine and you are injecting it. So it is much less costly. But if you are comparing, asking which one is the better one, so difficult to tell. I'll be keeping PRP little bit slightly. I don't know whether that slide is a statistically significant slightly or not, but little bit maybe the better. And still, I can tell ozone also works. And but unfortunate part of the ozone is the ozone research part, means number of publications in favor of ozone is less compared to that of the PRP. PRP, literature are flooded, lots of support. So that is another important reason why PRP is safer. If there is any complication, if there is any legal issues, you can easily safeguard yourself telling and showing the number of publications. Whereas ozone number of publication is less, much less. So that is another important area of the disadvantage.
Okay, sir. Thank you, sir. Thank you.
So see, today is this Kahoot. Take it as a revision of the upper limb nerve entrapments and the lower limb. I'll be explaining you after every slide. So even if you're making a mistake, do not hesitate, okay? And Dr. Krishna, if you are there, since I could see in the chat that this is the first time you're playing it, so you can change your answer within that 30 seconds frame if you want. Okay, and after that, it's not possible to change the answer because we'll be moving to the next question. So that is the one thing. And please listen to this carefully, because this is not only, just for the exam purpose. This will really be helping you in your day-to-day practice when you are just finishing up this course and seeing any patient. So you should not be missing your diagnosis, because until unless your diagnosis is correct, doing any intervention will not help. So let's start. So here goes your first question. The following test is used to diagnose carpal tunnel syndrome, radial tunnel syndrome, cubital tunnel syndrome, tarsal tunnel syndrome. So that was for cubital tunnel. Cubital tunnel, just remember, where is it? Always, for anything, you remember where is that particular structure present. So when we say cubital tunnel, this is on the medial aspect. Medial to posterior, you have the connection. So in that, you have this tunnel. So if you are going to flex, what you will be doing, you'll be trying to compress the flexor carpi ulnaris aponeurosis, and you'll be compressing the ulnar nerve. And if I'm doing the flexion, and what am I doing? I am just trying to compress that compartment. So if a patient who is already having an entrapment of the ulnar nerve over there, that patient will be saying, oh, it's paining, I cannot do that. So flexion at elbow, you will be asking the patient to hold this for approximately 20 seconds, or you just see this. And if the patient is having, the symptoms will start appearing in, the 1.5 fingers, and the patient is saying, I'm having this tingling sensation, this is very suggestive of cubital tunnel syndrome, means the entrapment of the ulnar nerve in the cubital tunnel. And that entrapment could be because of anything. It could be because of any osteophytes coming from the joint. It could be a lipoma. It could be an enconeus trochlea, means an additional enconeus muscle other than the normal, which is present. So it could be because of anything, but if this test is positive, that is suggestive of cubital tunnel syndrome. Moving to the next question. Just give me a second. The following ultrasound image is of cubital tunnel syndrome, carpal tunnel syndrome, radial tunnel syndrome, tarsal tunnel syndrome. So now let's discuss this image. See, I have not put the probe position deliberately, just to think, just to see, I should give whether you people remember the bones which are there. So see, I have given you a clue that where exactly my probe is, over the radius, lunate and capitate. So these are the bones where they are present. They are present. They are basically these two, lunate and capitate. They are our carpal bones. Radius, then your radiocarpal joint. So I have my probe is in the longitudinal axis, and if I'm seeing something which is having, see again, a dilatation, means this sign I have explained you, this is known as knot sign. Whenever you are going to have an entrapment of the nerve, you will be having a proximal dilatation of that nerve. So that proximal dilatation for the carpal tunnel syndrome, we call it as knot sign. And this, we see it in when you have the entrapment of the median nerve at the proximal carpal tunnel. Moving to the next question. All of the following are features of radial tunnel syndrome except finger drop, pain 3 to 4 centimeter below the lateral epicondyle, NCV normal, MRI normal. Yes, this is the right answer. Finger drop you see when you have the problem with your posterior interosseous nerve. Last time also I told you this is still a controversial thing, but now papers are coming more in favor of having the entrapment of the deep branch as radial tunnel syndrome and posterior interosseous nerve syndrome. Just one thing you remember. If you cannot remember anything, just remember few silent features. Again, I'm telling you, if it's a radial tunnel syndrome, you will not be having the finger drop. Finger drop means the patient is not able to extend the fingers. If the patient is not able to extend the fingers, means the nerve which is supplying them is the one problem with that nerve. In radial tunnel, usually there is no problem. There is the muscles, the nerve is fine. You have just the frictional, the stress injury, which is causing the problem in the nerve. But this extension of the fingers and all, everything will be there. You will be able to do the extension of the wrist nicely, extension of the fingers nicely. Means the PIN, when we say PIN when the deep branch comes out of the the distal portion of your supinator muscle, and after that it becomes PIN, and before that it is just the deep branch. So if you have the problem with your posterior interosseous nerve, that time you will be having the finger drop. NCV will be abnormal. MRI will also be showing the degenerative changes in the muscle, but you will not see all of this when you are having a radial tunnel syndrome. Moving to the fourth question, the following position is a risk factor for the entrapment of radial nerve, ulnar nerve, median nerve, musculocutaneous nerve. Okay, so what is shown there in this picture? He is flexing his elbow and he's doing his work. Right now, I think the first slide was about this only. When you flex your elbow, you have the entrapment of the ulnar nerve, which is known as cubital tunnel syndrome. Either this position or sleeping, with the flexed elbow. That also we should not be doing it. Fifth question, all of the following features are seen in the entrapment of ulnar nerve, radial nerve, median nerve, suprascapular nerve. So again, all those who have answered it wrongly, just see, she is a middle-aged woman. This is how I have explained it when I was taking the presentation. Middle-aged woman, in the night, she is having tingling sensation in 3.5 fingers. And when she is trying to shake her fingers, this tingling sensation goes off. She is not having any kind of tingling sensation over this thenar aspect because this is supplied by the palmar cutaneous branch, which is given off 5 centimeter from above the carpal tunnel, proximal carpal tunnel. That's why this area you will not, this in median nerve entrapment at the proximal carpal tunnel, this sensation over this area will be intact, but the patient will be having some kind of like the tingling, numbness, and all those things in 3.5 fingers, not on this area. So this is about the carpal tunnel, and we see this in carpal tunnel syndrome. Identify the structure marked with an orange circle. So you need to identify the structure, whether it's great saphenous vein, saphenous nerve, sural nerve, tibial nerve. Just look at the probe position, where exactly it is. No, saphenous nerve will not be there. Those who have answered it, now correct yourself. So this is the posterior aspect. Posterior aspect, what is the clue here? This is the Achilles tendon. This is saphenous vein, sural nerve. Next to the Achilles tendon, you are going to see the short saphenous vein and the sural nerve. So this is how you should correlate. Posterior aspect, you will be having in the subcutaneous compartment, you will be having sural nerve. If you go to the lateral compartment, you will be having your superficial peroneal. Anterior compartment is deep peroneal. Medial compartment is your tibial. Tibial is also there in the posterior, but that is too deep. So you will not be able to see the tibial nerve so superficial. All of the following are causes for. So look at this picture: tarsal tunnel syndrome, deep peroneal nerve entrapment, sural nerve entrapment, or superficial peroneal nerve entrapment. This picture I have taken from the slides which I have shared with you. So it is seen in tarsal tunnel. Now see, again, let me repeat all these things for you. There are two veins. One is your short saphenous vein. One is your great saphenous vein. Two nerve lying in the subcutaneous plane adjacent to the vein, that is your sural. So short saphenous, it is sural. Great saphenous, it is saphenous nerve. On the medial compartment, you are going to have your posterior tibial artery. Posterior tibial artery, tibial nerve. So FHL is, where is this present? It is present on the medial compartment. Varicosity of the posterior tibial vein, that was the clue. So posterior tibial vein, obviously you're going to have the posterior tibial artery. And when you have the posterior tibial blood vessels adjacent to that, you're going to have your tibial nerve. In the anterior ankle, you have your deep peroneal, and that deep peroneal will be having your anterior tibial. So anterior tibial artery in the anterior compartment, posterior tibial artery, though the name is like posterior, so do not get confused, though it is present in the posterior, but it comes to the medial compartment. So remember it for the basic course: anterior tibial artery, deep peroneal nerve. Go to the middle, you have your posterior tibial artery and then tibial nerve. You go to the lateral side, you have your superficial peroneal. You go to the posterior side, you have your sural nerve. So this is how you need to revise it again. And these are the tendons. You have your tibialis posterior, which is just lying posterior to your medial malleolus. So if you are going to have the tenosynovitis of this, or you have the tenosynovitis of your flexor pollicis longus, obviously that will be compressing the tunnel. So we are going to have the tarsal tunnel. This tarsal tunnel is present on the medial ankle. That's why these tendons are also on the medial ankle. So if you have problem with them, they will be compressing the tunnel. Oh, just give me a second. I stopped sharing it. So sorry for that. Okay, moving to the next 8th question. The great saphenous vein accompanies the following nerve. Let me see who all are gonna do it, not gonna mark it correctly. Let me see. Right now I explained. See, right now I explained. Great saphenous vein is saphenous nerve. Short saphenous vein is sural nerve. So again, so many wrongs. Okay, do not do this mistake again in the final evaluation. The following is the nerve of the anterior compartment: deep peroneal nerve, superficial peroneal nerve, tibial nerve, sural nerve. Again, so many wrongs. Okay, I'm revising again for all of you. Deep peroneal nerve is the nerve of the anterior compartment. Superficial peroneal nerve is the nerve of the lateral compartment. Tibial nerve is the nerve of the posterior as well as medial compartment. Sural nerve is present on the posterior aspect. Last question. The following can be identified at approximately 7 to 9 centimeter above the lateral malleolus. Superficial peroneal, femoral nerve, common peroneal, tibial nerve. That is superficial peroneal. You put your probe in the short axis approximately 7 to 9 centimeter above that, above the lateral malleolus, and you will be seeing two compartments, the lateral compartment and your anterior compartment. And you will be able to see the superficial peroneal nerve, which is lying in between these two compartments and then coming superficially. So that is how you locate it. So that's all for today, I think. Okay, let me play the music. So Dr. Anindam, congratulations on the third position. Subhashish, the second, great. Let me see who is on the top. And really, congratulations. And Dr. Kaustav, if I'm not wrong, in on this position is Dr. Singh. So this is all of you. So let me stop sharing the screen. So I think I have revised this upper limb entrapment and the lower limb today with you. So I hope you won't be doing any mistakes when I'll be asking you questions in the final evaluation. So study, and if you have any problem, you can always ask us. Yes, sir, you are about to say something.
Yes, I was telling that this was the last one, and we have tried to answer all your questions. We hope that you enjoyed the course. And before that, within next 1 or 2 days, we'll be sending you a link for your evaluation of this course, how you liked it, what are the areas where we can improve it further in our subsequent similar courses. So we run different courses parallelly, and your feedback is really important for us, not for you. It is important for our own improvement. So where the areas where you liked, please encourage us, and the area where you didn't like, please tell us how we can improve it. So we'll be sending you the link by a few days, and I hope that before the next week, we all will be getting this evaluation link. And remember one thing, this is mandatory. We have to have this evaluation form filled up. And best of luck. Study whatever was there, supplied to you. The most questions will be like that only, whatever you have seen. And what I feel my overall assessment is, some are doing very good, but some, very basics are also, there was mistake. So this should not be there. To be pain physician, at least some basic knowledges might be there. Basic knowledges must be sound. You should not be having any doubts about it. And after the course, it is not the relations with us is not completed. So even if in the future you are having any doubts, any problems in your practicing, you are always welcome to ask questions to us. So this is what
I have a question to ask if from fluoro, if it's possible.
Yes, we are practicing both fluoro and USG.
Actually, I was revising the fluoro part. So in that, it was mentioned that when there is a traversing nerve root and exiting nerve root. So for example, in the L4, L5, like I wanted to ask the two concepts, I got confused in between. One was this, and the other one, when we apply facet block. So for example, if we are applying facet block in L4, L5, then the median nerves that we block are L3, L4, right?
So where is the confusion?
The confusion was whether I'm right or not. Like because the two concepts I was mixing between the L4 L5 traversing wala concept
You
and
see,
this concept.
okay. Let me show you some picture. Then it will be. Let me share some picture. Then it will be easier for you.
The
Just give me-
meantime, when sir is sharing the picture, I will be announcing the top 3 participants of this batch next time. I'm almost done. I have to calculate now the 4 scores of like today's 3 Kahoots. And I would be very happy to announce them because they have been there dedicatedly attending all the Kahoot sessions. So, but you need to wait.
Okay, look at this image. So this is your L5. This is S1. This is L5. This is L4. So at the level of the L4 5, the route, what is exiting? What is this route? L4.
This should be L4.
L4 5 level, the exiting nerve route is your L4. And which nerve is traversing at this L4 5 level? Traversing nerve route is here. So
L5.
the L5 nerve route is traversing at the level of the L4 5. Is it clear? If it is L3 4, then exiting nerve route is your L3. Because nerve route exits at the same foraminal level. And nerve route which is exiting next level is traversing close to that. That is called lateral recess. This area is called lateral recess. So this nerve route which is exiting at this level is traversing to the lateral recess at this level. That means at this level, this nerve route is exiting and this nerve route is traversing.
Right.
Is the concept is clear?
Thank you so
Okay.
much. Yes.
Now look at your second thing. So this facet joint is what? L4-5 facet joint, right? So these L4-5 facet joints, how it will be innervated? One nerve root will be coming on the same level and another nerve root will be coming from here. This upper part will be coming, medial branch, this nerve root is divided into here and here. The medial branch will be there. That means if it is an L4-5 facet joint, this will be supplying the lower part and this will be supplying the upper part. That means L3 and L4 will be supplying the L4-5 facet joint. Right?
Okay,
is it clear?
sir. Yes, sir. Now it's clear, yes, sir.
Okay.
Thank you, sir.
Okay, so good luck.
Sir,
And
one thing I want to tell, because there are so many people who are asking before you could finish the session. It will be from 6 p.m. to 8 p.m. next Friday. Questions will be MCQ based. We will be conducting them in Kahoot, like the way we are conducting. That's the reason we were telling you, please get acquainted with Kahoot. And that's all. And 20 questions from USG, 20 questions from Siam. You need to score 50% in each. Means out of 20 questions, your 10 questions should be right in Siam, your 10 questions should be right in your ultrasound. And then we will be announcing the final, score, maybe after a week. So I hope that clears all your questions. So now, sir, please carry on. Sorry to interrupt you because I thought, they should.
No, nothing. I was going to finish end today's session. It is almost 9.
One question.
Yes.
So clinically, patient presented as a frozen shoulder, and in
Right.
MRI it shows osteoarthritis of acromioclavicular joint along with the supraspinatus partial tear. Then, sir, what procedure I should do? in
You
that
see,
case?
always this is not just for shoulder. Always there are two parts of the evaluation. One part is your clinical evaluation, another part is your investigation. And in each areas, the clinical diagnosis is more important than the image. Why? Because many of the image are asymptomatic. That means, suppose somebody is having a tendinopathy. In fact, we are conducting this study. So tendinopathies, asymptomatic patients having tendinopathies. So clinical diagnosis is more important. Now, clinically you assess what are there, and finally you match with the ultrasound or MRI. and finally you decide that which areas to be attempted, right? So
Okay,
it is not, there is no a single short answer that you should do this one. But finally, you have to understand that whether that pathology, that means what pathology you are identifying with the USG or MRI, whether that pathology is going to produce these clinical symptoms or not. If you feel that this pathology seen in the MRI is not going to produce any symptoms, then don't try to touch it unless it is dangerous. Suppose, sometimes there is a partial tear. Right now might not be, but maybe a complete tear in the future. So even if that is remaining asymptomatic, you should address it. But if it is only tendinopathy, if it is only tendinosis, no symptoms, then you need not do anything. So that means two part, and you have to have a judicial decision based on your clinical findings as well as the image, and finally you decide how to do.
Sir, in frozen shoulder, injection should be given in intra-articular space or?
Frozen shoulder, the pathology is, if it is giving, there are two parts of it. Already probably it was discussed. The most important part is if you are distending the capsule, then there will be distension of the capsule is important part of this. But apart from that, coracohumeral ligament also plays important role. So you can, during the distensions, particularly if you are giving the injections through your rotator cuff intervals, so this part can also be taken care. But remember, frozen shoulder, intra-articular injection is important, and distension of the capsule is important.
Okay. Thank you, sir.
And this is also very important and message I normally tell several times, that don't treat your image, treat your patient. So whatever is there in the image, you have to match with your clinical findings and then finally take a judicial decision. Suppose a tumor is there, which is asymptomatic, tumor might be malignant, you must be doing that thing. But if you see some degenerative changes, which is remaining asymptomatic, you need not treat that conditions. So in that way you have to take. There is no simple, clear-cut, single-line answer for it. So, but clinical features, is always on the top than the image findings, because many of the image findings remains asymptomatic, which need not be addressed.
Thank you, sir. Kanchan ma'am, I want to ask a question from you. Yes, ma'am. Ma'am, on the medial aspect of knee, in sonoanatomy, how can we differentiate between the medial collateral ligament and tendons of pes and serinus?
It's very easy. I'll tell you how. You put your probe in the coronal plane over the medial collateral ligament. You keep on tracing the ligament, and you will see that the ligament will be attaching on the plateau of the tibia. Okay, so when it is attaching on the plateau of the tibia, on the top you will be able to see three rounded things. So those are the cut sections of those, the tendons, and if you trace them up, they will become muscle. So that is how you distinguish between them. They will be on the top of that. And if you have a bursa there, but until and unless that bursa is enlarged, you will not be able to see anything. So if there is a fluid, you will be able to see the fluid like an E-shaped thing between these tendons, because this tendency, they are coming like this. We are putting the probe like this. So you will be able to see them like this, three, a beaded like structure. And if you have a fluid around them, it will be like an E-shaped. So that is how you distinguish.
Another thing I'll be adding, if you are flexing the knee, normally the tendons comes in, the medial collateral ligament is on the above and the tendons comes below, if you're flexing the knee.
Okay, thank you, sir. Thank you, ma'am.
In confusion, always what I do, trace them up. That is, another thing. And one thing more, which I would like to say, which sir used to say, when I was with sir, I think 6 years back, I remembered, because now Dr. Praveen asked how to treat. So sir used to say, if a patient is having, if you're taking an MRI, there is a disc bulge, patient is not having, like I had this. So I'm just telling you, I'm sharing my own thing. I was having a bulge at L5S1. And, I got my surgery also done. My pain was still there. And when I had been in touch with sir said, you are a patient of, ankylosing spondyloarthropathy. We say it ankylosing spondylitis. So I have that SI joint pathology. So what is this? What has happened with me is like everybody has treated not my, pain, but they have treated my image because there was a bulge there. But sir was the one who could diagnose that and who has treated me. And since then, I think it's been 6 years, I don't have any pain. So that's the importance. I'm just sharing my personal experience with all of you, just to tell you people how important it is to diagnose your condition, to just correlate your clinical findings with the image, not even a single. Being a doctor, imagine, I would have visited so many people. So that is the beauty of your history and your clinical examination. So do not miss these two and directly jump to an image. Otherwise, someday some patient will be saying like how I am telling. So for that, I think I was very grateful to sir. And that was, I think, the day I joined sir, almost 6 years down the lane. So sir was the one who diagnosed that. So that is how strong you need to be in your clinical diagnosis. Okay, I think that was all for you, so that you learn from our experiences, from our things. And anything else, sir, or can we just end the session today?
Yes, let us end the session. It was an exhaustive session, but okay, only one day we'll be missing.
Yeah, I'm gonna miss everyone. I'm gonna miss
we'll
them
be missing
a
after
lot.
the last class.
Thank you so much, sir.
Thank you, sir. Thank you, madam. Thank you, sir.
Okay, bye-bye. Good night.
Thank you, sir. Thank you, ma'am.
Thank you.
Thank you. Good night. See you next time. Study well. Bye-bye.
Yes, ma'am.